Hello everyone and welcome back to ACE Achievers. Today's topic is the unfavorable sequelae of malocclusion, and I'm Dr. Vartika Chadda and I'm MDS in Orthodontics. So as you can see on the two pictures behind me, we have the ugly duckling who looks very ugly. So people are pointing fingers and pointing out the imperfections. Whereas the child who is suffering from a malocclusion and a bad appearance also feels like an ugly duckling whose insecurities and imperfections are constantly being pointed out. So one of the biggest problems with having any sort of a malocclusion is that the person feels that they look ugly or they do not look normal, that there is something wrong with how they are. So they feel bullied or insecure, which ultimately will lead to psychological problems as they turn into adults. So if the child is able to resolve this psychological problem, this insecurity, it is well and good. But if the child is unable to resolve this can lead to some deep psychological problems. So it is very important for a child to be made to feel comfortable with the way he or she looks. Then of course, where it actually stems from is a poor appearance. So as you can see over here, the child may have a very large lower jaw or a class 3 malocclusion, which will make him look a little different from others. Similarly, children of cleft lip, cleft palate look a little different from others, and since it's a defect that involves the face and the lips, they often become very easy targets to bullies, and often people point out the defect to them and they are made to feel lesser than any other child. Then we come to a very important aspect which is often overlooked by even dentists, is that any kind of a malocclusion can ultimately hamper the natural growth and development of the child. So for example, if a patient comes to us with a class 3 which is an anterior crossbite, so not only is the appearance poor or the speech hampered, but as you can see, the lower jaw will completely cover the upper jaw and prevent the growth of the upper jaw. So this will hamper or finish rather the growth of the upper jaw, ultimately leading to a crossbite, ultimately leading to a class 3. So an anterior crossbite can be the cause of a class 3 as well as a symptom of a class 3. Similarly, over here, as you can see, the upper arch is constricted, the lower arch is bigger. So the patient, in order to attain maximum intercuspation, has shifted the mandible to the left side. So this is another reason why he will or she will look asymmetrical. So not only will the patient have an asymmetrical jaw, the patient will again have a class 3 malocclusion and will ultimately face TMJ problems later on in their life because of a jaw deviation, as he or she is unable to attain maximum intercuspation. Then we come to abnormal muscle function. So abnormal growth, abnormal development will ultimately lead to abnormal muscle function. So any abnormal function can be the reason of a malocclusion, and it can also stem from a malocclusion. So again, it is a reason as well as a symptom. So if you see this child is unable to close her mouth because her teeth are protruding out. She has a very severe class 2 with the maxilla placed prognathically or in front. So because she is unable to close her upper lips, the buccinator mechanism is hampered. The patient has incompetent lips. So incompetent lips will hamper your growth and will lead to excessive growth of upper jaw, which will again lead to incompetent lips. So this is a vicious cycle. Growth or buccinator mechanism. So incompetent lips will hamper our buccinator mechanism, which will ultimately lead to excessive growth of the upper jaw, and which will ultimately lead to incompetent lips. So once you get trapped in this cycle, then the jaw will keep growing and the class 2 will keep worsening for this child. Similarly, over here the patient has an open bite. His upper and lower teeth do not meet. Due to this, you can see there is a big hole in the front. This will lead to tongue thrusting, because when the patient tries to swallow, he or she will not have adequate anterior seal. In order to attain the seal, he or she will push the tongue forward, leading to tongue thrust. And tongue thrust will in return cause worsening of the open bite. So another vicious cycle develops right here. Then we come to abnormal deglutition. Now this is the functional aspects of malocclusion. We have seen that malocclusion will lead to poor appearance, bullying in school, psychological issues, but it will also hamper the function of the child. Improper swallowing can be due to a number of reasons. First of all, being over here, you can see a cleft palate. So because the palate of the patient is unrepaired, it is undeveloped, the patient will not be able to swallow. Whatever he or she will try to swallow, it will go directly into the nasal cavity, leading to further infection. Because of a lack of palate, the tongue will push all the food into the nasal cavity rather than the throat. The second common cause of abnormal swallowing is abnormal tongue position. If we do not position our tongue correctly behind the upper incisors, we develop a habit called as tongue thrust. And tongue thrust can be due to abnormal tongue position, which will in turn lead to abnormal deglutition. Then we come to abnormal jaw relation. So any kind of a jaw relation which is present, which is a severe class 2 or a severe class 3, will hamper our tongue position and will hamper the way we place our jaws, which will hamper in turn our swallowing. And abnormal muscle function. Now deglutition or swallowing can be of two types, which we have already studied, infantile and normal swallow. So if we have an abnormal muscle function, our swallowing can cause tongue thrust, and tongue thrust is a result of abnormal muscle function. Improper mastication. In cases of people who are not treated and they have a very severe malocclusion, even their mastication or even their chewing habit gets altered, because malocclusion means a bad bite. And if our occlusion is not proper, we all know that we ultimately, it hampers our mastication. It hampers our major ability to chew the food properly. If we don't chew properly, it will lead to a digestion problem, because the food is ultimately entering our stomach where it is giving us nutrition. Once digestion is hampered, it will lead to nutritional deficiencies, it will lead to many stomach issues, and it can even lead to severe gastric problems in the life of the patient. Similarly, if you have seen edentulous patients or patients who do not have posterior teeth, they come to you with being unable to eat at all, and along with them, if you take a proper history, you will learn that they cannot chew, and because of lack of chewing, they have developed severe stomach issues and liver issues even. So a very severe malocclusion can cause improper mastication. Then we come to speech defect. So as you know, in the act of speaking, we touch our tongue to various parts of the mouth, and also our lips move a certain way on our teeth, and only then are we able to produce the sounds that we produce. So if our teeth are placed in a position where they are not supposed to be, say they are placed too much in front or they are placed too much in the back, then our speech is definitely going to be hampered. Similarly, as you may have seen in the previous picture of the cleft patient, now the palate is not there. So where is the patient even supposed to place his tongue? He or she will definitely have a speech defect. Not only is chewing a problem, not only swallowing is a problem, but even speech for such patients is problematic, because they do not have an anterior seal, they do not have an anterior stop, they don't know where to place their tongue on the incisors. So an inherent speech defect definitely develops in especially cleft patients or in patients of anterior open bite. Even patients like these, they often come to us with a lisp because the tongue is between the teeth. The tongue is not behind the teeth. To speak, the tongue should be behind the teeth, but it is between the teeth. So patients like this have a lisp. They definitely have problems in speech, something which we will be talking about later on as well. Then dental caries. So dental caries is an issue that you may have read about a lot, and you know one of the major cause of caries is streptococcus bacteria, which gets lodged into the in between teeth, on the fissures of teeth, in the pits of teeth, and it starts getting fermented and acid is produced. So one of the very common types of caries is class 1 caries, which develops in pits and fissures. Why does it develop in pits and fissures? Because pits and fissures serve as an area where food can go and get lodged. Similarly, if you have irregular teeth that do not have proper contact, so the key here is improper contacts. Improper contacts will serve as retentive areas for food and bacterial products, which will lead to fermentation of these products by bacteria and will cause caries. So improper contacts which are not self-cleansable. If they are self-cleansable, then no caries will develop. If you have a situation like this, where the mesial surface is contacting the palatal surface, or the mesial surface is very buccally placed, the distal surface is improperly contacting the canine, you will see a lot of caries even in the anterior teeth of young patients. So these kind of patients get very irritated or do not have poor aesthetics, not just because of crowded teeth, but because of cavities. They have multiple RCTs that are going on, they have extractions going on. So these are ideal candidates so that their teeth get straightened, their contacts are perfect, and therefore their cavities will ultimately decrease and they will be able to maintain better hygiene. Then temporomandibular disorders. So problem, as you know, with a bad bite is ultimately the joint. The joint is ultimately going to get affected. So TMJ problems do not develop in teenagers or young children. They will not come to you with clicking joints. It mostly occurs if a patient has had a malocclusion for 20-30 years of their lives and now they are adults or they are young adults, and then their joint starts clicking because of the bad bite. So this is kind of a chronic effect of a malocclusion. If the malocclusion is overlooked for a long period of time, then they will come to us with clicking of joint, then they'll have TMDs. So why the ultimate problem will ultimately lie with the fact that they have had a bad occlusion which has led to improper muscle function. So bad occlusion or a malocclusion will lead to abnormal musculature, which we have already learned about. Abnormal muscles can cause two things. One is a bruxism habit or a over or under closure, and all of this will lead to TMDs. One of the many reasons of TMD is bruxism, overclosure, underclosure, any kind of a premature contact, severely malposed tooth, a tooth that is very palatally placed or very buccally placed, will all cause stress in the TMD, will all cause damage to the TMD, and the patient will present to you with facial pain. The patient will have clicking, all of the classical symptoms right here. They will have, even if you palpate their musculature, you will notice a very tight band on wide opening, on small opening, and they may also have gone to an ENT before you with ear pain. So all of these TMG functions will be presented to you. So let's quickly go over how various malocclusions can cause a TMD. So if you have a posterior crossbite, what happens is you try to close your mouth in maximum intercuspation. But you cannot do that because your upper jaw is small. So this is inherently because of a deficient maxilla or an constricted maxilla. So a posterior crossbite will be accompanied usually by a constricted maxilla, and because of that the patient will try to bite, but this will ultimately lead to a deviation of jaw to attain full or maximum intercuspation. And when this is not obtained, the patient will try to deviate the jaw, which will lead to abnormal muscle function and ultimately TMD. Similarly, if you have an excessive overjet, like we saw 10 mm, 14 mm, or an anterior crossbite, the anterior contact will not be present, or rather the incisal guidance will be absent. So anterior crossbite, excessive overjet have absent incisal guidance, which is very essential for occlusion. And lack of proper occlusion is what is causing abnormal muscle function and your TMD. Now, crowding may or may not manifest as a TMD. It is not always present. Crowding can actually cause more of caries, more of periodontal issue, but certain features have an abnormal contact. So even one abnormal occlusal contact will act like a high filling. So this can cause two problems. One is obviously TMD. The second is your periodontal issues, which stem from trauma from occlusion. And lastly, a deep bite, what it does is, if it is a skeletal deep bite, it causes overclosure of mandible. And this overclosure is attributing to your TMD. Then we come to the periodontal situation. Now, if you see the gingiva of a mouth breather, you will see that he or she will always have marginal gingivitis. So, mouth breathing being a habit or etiology as well as a result of a malocclusion will lead to marginal gingivitis and even marginal enlargement in teenagers. Also, as you can see, crooked teeth are not very easy to clean. Like this tooth will be very difficult to floss, very difficult to brush, and very difficult to, if food gets stuck here, it will be very difficult to take out that food. So all of this will ultimately contribute to caries and a periodontal disorder. So any kind of a unself-cleansable contact or a poor contact will lead to food lodgement, ultimately leading to periodontal diseases. Also, tipped teeth will cause periodontal issues. And most importantly, over here you can see there is a certain kind of a TFO that is developing. Any kind of a trauma from occlusion is very bad for the ultimate gingival health and periodontium of the tooth. So this is causing some certain degree of TFO, which will lead to bone loss and will definitely accelerate the loss of this tooth. It can, later on get on to becoming mobile, and it will be very, very hard to replace the missing tooth also, especially in class 2 div 2. If you have seen class 2 div 2 has a very severe deep bite. So a severe deep bite will cause the upper incisors to damage the gingiva of the lower teeth. So upper incisors will touch on the gingiva of the lower teeth. So upper incisors will ultimately lead to traumatic, abrasions of the gingiva, and lower teeth will lead to trauma of the palatal mucosa. So upper teeth lead to damage of gingiva of lower incisors, and lower incisors damage the palate. And all these kind of improper, premature contacts, any TFOs will lead to mobility of teeth, and ultimately they will have to be extracted. One of the biggest reasons to treat a child early is that the child might fall and break his teeth. So this is a situation that develops in class 2 div 1 children who have a very, very increased overjet. Once you have a very large overjet, there is a very big tendency that the child, when he's running, he's playing, he may fall and break his teeth, or a ball or something might hit his face and break these teeth, which can lead to loss of vitality of tooth and avulsion of teeth, and in severe cases the tooth might be lost and the child will have to do with a prosthesis for the rest of his life. So a predilection to accidents, a predilection of loss of an anterior tooth is a very severe trauma to the child. It can hamper his appearance, it can hamper his self-confidence. So all of this will ultimately stem from the fact that he had an increased overjet, he had a class 2 div 1 malocclusion. Then we come to impacted or unerupted teeth. Now impacted teeth does not necessarily mean that they are third molars. They can also be canines. Over here you can see the canine is impacted, it is impinging on the central incisor. It can also be a premolar. So any prolonged retained deciduous tooth or even a premature shedding of a deciduous tooth can lead to impaction. So that can be the etiology, which we will be studying about later on. And an impacted tooth is a very difficult situation to treat for an orthodontist. Even if we extract the impacted tooth, it is a surgical intervention and it will definitely hamper the growth of the child, and even replacing a tooth like a canine or a premolar is a Herculean task, especially if we have an impacted canine what we are looking at. To replace it, it is very, very difficult. And secondly, any kind of an impacted tooth, as you can see, will hamper the roots of the developing incisors in case of a canine, and in case of an 8, as you can see, they always tend to damage your 7s. So an impacted tooth not only damages itself, it also damages the teeth surrounding it. One of the very, very big reasons why we ask our patients to undergo orthodontics, especially an adult patient, is a premature loss of a permanent tooth. So if the permanent tooth is lost, you may have heard that the upper tooth starts to supra-erupt and the lower teeth start to tip into the extraction space, and you come up with a situation like this. So initially the patient may not be having a malocclusion, he or she may have perfect teeth, but due to caries or periodontal issues, they would have to get a 6 extracted or any other tooth extracted for that matter. Now the other teeth have started to tip and to move unfavorably, and for that reason it has become very, very difficult to replace this missing tooth, and for that reason the patient wants to undergo orthodontic treatment to untip these teeth so that he or she will have space for prosthesis. So very big indication for orthodontic treatment is a situation like this, that you have complications in a prosthetic rehabilitation, and to make the job of a prosthodontist easy, you are asking the patient to undergo an adjunctive orthodontic treatment. So very common to see these days that you are carrying out treatment just for 6-7 months to correct a situation like this. So this brings us to the end of our lecture. Thank you for being patient listeners. This is not a topic that is usually asked as a long question. It is asked as a short question. So please be ready with these points on the top of your head. You should remember at least to list them down and to explain them in your answer sheets. Thank you.